Episode 42, Swollen Knee After Surgery. Welcome to Sports Medicine Case Studies, where I review published case studies, discuss key takeaways, and provide some practice questions. Today's case is a 22-year-old female recreational athlete who was involved in a motorcycle accident resulting in polytrauma to her pelvis and multi-structural damage and dislocation of her right knee. Prior to her injury, the subject was physically active in recreational athletics involving running and gymnastics. The patient had high functional expectations for return to sport and activity after her injury. The past medical history included anxiety, depression, and attention deficit disorder. There was no medical or family history of immunologic or autoimmune conditions. After the accident, an MRI revealed a complete disruption of the ACL, PCL, LCL, anterolateral ligament, popliteus tendon, and iliotibial band. Other findings included an avulsion fracture of the medial femoral condyle and a peripheral lateral meniscus tear. The subject underwent posterior lateral corner reconstruction and lateral meniscus repair 8 days after the accident. She completed approximately 4 months of physical therapy before undergoing a second stage procedure where she underwent an ACL reconstruction with hamstring autograft and PCL reconstruction with allograft, with both grafts being reinforced with suture augmentation. The patient completed 2 months of postoperative physical therapy before acutely presenting with knee swelling, pain, and inability to bear weight. 1 week prior to the onset of these symptoms, she underwent elective cosmetic surgery with fat autograft harvested from the contralateral thigh. On examination, the authors described a large knee effusion, inability to move the knee without significant pain. My differential diagnosis: infectious complications from previous surgery or rheumatologic disease. I want to recognize the authors. Today's episode examines a case report published in the International Journal of Sports Physical Therapy by Moore, Zeppieri, Roach, and Rademacher in 2026. I am Scott Hall, a primary care sports medicine physician, and I am studying for my sports medicine certification exam in November of 2026. I hope you'll join me on the journey. This podcast is for educational purposes only. Okay, so the patient presented, she was evaluated emergently, and an aspiration of the knee was performed. Laboratory findings from the aspiration were consistent with septic arthritis. She underwent emergent knee arthroscopy with irrigation debridement and had a peripherally inserted central catheter placed for IV antibiotic therapy. Subsequently, she improved and re-engaged with physical therapy. However, a change in insurance coverage resulted in reduced authorized visits and temporarily constrained rehabilitation frequency. Subsequently, the patient did independently resume higher level physical activity and returned to coaching gymnastics at 28 weeks. I am perplexed by this decision to undergo a cosmetic procedure after a significant orthopedic procedure was done previously. The optimal interval between orthopedic reconstruction and a subsequent elective procedure is genuinely debated. Some evidence cited by the authors suggests 6 to 12 weeks is sufficient to prevent infection in a previously operated joint. This patient's cosmetic procedure occurred at 8 weeks inside that supposed protective window. Regarding the development of septic arthritis, the authors are appropriately cautious here. Causation cannot be established from a single case, but the timeline is difficult to ignore and its practical implication is clear. Patients undergoing sequential surgical procedures may carry increased risk of delayed infection and postoperative complications. So the authors didn't share what the laboratory analysis showed from the initial aspiration, nor did they provide a description of the causative organism. A couple of key takeaways from me: septic arthritis is a joint space infection that is an orthopedic emergency. Cartilage destruction and permanent joint dysfunction can begin within 24 to 48 hours if antibiotics are delayed, and mortality is reported at 2 to 15%. It should be assumed in any acute atraumatic monoarticular painful swollen joint that this could be septic arthritis until arthrocentesis proves otherwise. Synovial fluid analysis is the diagnostic cornerstone of this evaluation. The risk for septic arthritis rises with a couple of risk factors: age greater than 80 years old, diabetes, rheumatoid arthritis, prior joint surgery or prosthesis, skin infection, injectable drug use, and immunosuppression. Noting that anti-TNF therapy carries a higher risk than non-biologic disease-modifying antirheumatic agents in patients who are managed for rheumatologic disease. Staph aureus, including MRSA and Streptococcus, are the bacteria that tend to predominate for septic arthritis. Gram-negative bacilli cause about 23 to 30% of cases in older adults. Neisseria gonorrhea in sexually active adolescents and young adults is also an important consideration. The knee is most commonly involved at about 50%, followed by hip, shoulder, ankle, elbow, and wrist. The diagnosis is of course made by arthrocentesis before antibiotics, with the fluid sent for further testing, including gram stain, aerobic and anaerobic culture, cell count with differential and crystal analysis. In the synovial fluid analysis, the white count less than 50,000 would argue against septic arthritis, but it does not exclude infection. And the presence of crystals also does not exclude coexisting sepsis. ESR and CRP are sensitive but nonspecific. In children, there are what are called Coker criteria, and I'm going to describe those. So it is a fever greater than 101.3 Fahrenheit, a sedimentation rate greater than 40, a white blood cell count greater than 12,000, and an inability to bear weight. When those Coker criteria are fulfilled, there is a high likelihood of septic hip arthritis or septic joint arthritis. The Coker criteria can be used to distinguish septic arthritis from transient synovitis, but again, arthrocentesis remains diagnostic. A couple of questions for you. Number one, a 62-year-old former collegiate wrestler with a history of gout presents with an acutely hot, swollen knee. Aspiration reveals negative birefringent needle-shaped crystals with a white blood cell count at 32,000, 88% PMNs. Which statement best reflects appropriate management? A, crystals confirm gout and exclude infection, treat with colchicine and discharge. B, crystals reduce but do not eliminate the probability of concurrent septic arthritis. Send cultures and consider empiric antibiotics based on the clinical picture. C, synovial PMN percentage is the most reliable discriminator in crystal positive fluid. D, a synovial lactate less than 4 would confirm septic arthritis. E, antibiotics should be withheld until final culture results return. The answer here is B. The presence of crystals alone does not exclude septic arthritis, and elevated synovial white blood cells and CRP are common in both crystalline and septic arthritis. In a series of 302 aspirations, septic arthritis was present in 4% of crystal positive evaluations. Okay, question 2. A sexually active 19-year-old female Division I volleyball player presents with a 5-day history of migratory polyarthralgia, tenosynovitis of the wrist and ankle extensors, and scattered pustular skin lesions, now with a warm right knee effusion. Synovial gram stain is negative. Which of the following is the most appropriate initial therapy? A, oral doxycycline. B, ceftriaxone 1 gram IM or IV every 24 hours. C, vancomycin plus a cephalosporin. D, oral levofloxacin, and E, observation pending culture. The answer here is B. The clinical triad of migratory polyarthralgia, tenosynovitis, and dermatitis in a sexually active young adult is characteristic of disseminated gonococcal infection in which synovial gram stain may be negative. Ceftriaxone is the recommended agent for gram-negative cocci or clinically suspected gonococcal arthritis. Doxycycline should be added if chlamydial co-infection has not been excluded. Neisseria gonorrhea should be specifically considered in adolescents and young adults with septic arthritis. Question 3. A 6-year-old boy is brought in with refusal to bear weight on the right leg, a temperature of 38.9 degrees Celsius, a sedimentation rate of 55, and a peripheral white blood cell count of 14,000. He holds the hip in a flex, abducted, and externally rotated position. Which of the following is the most appropriate next step? A, empiric oral antibiotics and outpatient follow-up in 48 hours. B, MRI of the pelvis before any intervention. C, ultrasound-guided hip aspiration with fluid sent for analysis, including cell count, gram stain, and culture. D, NSAIDs alone as transient synovitis is most likely. E, plain radiographs alone to exclude septic arthritis. The answer is C. This child meets the 4 Kocher criteria with a fever greater than 101 degrees Fahrenheit, an ESR of greater than 40, a white blood cell count greater than 12,000, and non-weight bearing. These factors strongly favor septic hip arthritis over transient synovitis, but arthrocentesis remains the definitive diagnostic step, and ultrasound is the appropriate modality to guide the aspiration of the hip and other inaccessible joints. Synovial fluid in pediatric bacterial arthritis typically exceeds 50,000 and is often greater than 100,000, which contrasts with a count of about 5 to 15,000 with mononuclear predominance in transient synovitis. Klebsiella klingae is the leading pathogen in children under 4 years old and may require molecular detection, and an MRI is reserved for suspected concurrent osteomyelitis or soft tissue extension and should not delay aspiration. Thank you.